You're tuning into the Active Mom Podcast with physical therapist, Dr. Carrie Pagliano, a real mom's guide to all things postpartum return to workouts after baby. If you're a postpartum mom, coach, trainer, or physical therapist looking for answers on how to get back to running, CrossFit, yoga, Pilates, HIIT, you name it, without the fear of pelvic floor issues or doing something wrong, this is the podcast for you. Let's start the show. All right. I think 2023 has been the year of talking about hormones, whether you are pregnant, postpartum, perimenopause, menopause, it's kind of everywhere. And any place I go, I'm talking about it with my friends. And so I have invited Ashley Winter. She is a urologist in California, and she talks about hormones a lot over on Twitter, whatever it's called this week. And sometimes over on Instagram, where it is a little bit nicer. But Dr. Ashley Winter, welcome to the Active Mom Postpartum Podcast.
Hi, thank you for having me. You're so right about those two platforms. I posted the same exact content on both Instagram and Twitter/X yesterday. And on Twitter/X, I got called a lot of vile names.
Mhm.
And then on Instagram, for the exact same content, people said, "Oh, this is so empowering. I'm crying reading this." And you're just like, the vibes are so different.
We're bringing you over to the happy place. Like, I mean, I will go
It is.
to Twitter again, whatever it's called this week, for certain kinds of information. But no, it's happier. So come on over.
I know. It sucks because I
I
love
know.
the
I
format
know. I hear
of
you.
the
I hear
Twitter.
you.
I love it, but it's like the vibes are
I
so
know.
bad.
I know. Well, tell us a
I
little bit about kind
Yeah.
of who you are, where you're from, and like you've gone through a bunch of big changes this year too. So why don't you tell us a little bit about that?
Yeah, sure. So, who am I? Again, I'm a board certified urologist. I did my residency in urology in New York City at Cornell, and I um, did a fellowship in male and female sexual dysfunction after that. In part, I did the male and female sexual dysfunction fellowship because I felt like a lot of the common sense, or the common concerns that patients were coming to my clinic with were not really being addressed by the knowledge I was being given, right? So you had, in a urology residency, you learned how to take out a bladder, to take out a kidney, to know every single thing about the latest prostate cancer therapeutics. But then you would have a clinic day and a patient would come to you and say, "It burns when I pee, but I don't have an infection." And you'd say, I don't know how to deal with that.
Yeah.
I just had 400 hours of lectures on prostate cancer, but I don't know how to deal with that. and um and that was so frustrating, right? Because I had a gazillion years of education, and I felt like I needed to give real solutions to problems like that, and not just say, "Well, you're not dying, so it's okay."
Right.
Right? Um, and the fellowship really gave me a lot of tools to address a lot of concerns that I hadn't been able to address before. So that's kind of the background. Um, I was working at a large managed care organization as an attending for 5 years after fellowship, and then I left um, to be more entrepreneurial and work on a bunch of different projects in the health tech space, because I do believe that we need to enact a lot of change really fast
Yeah.
to improve sexual health care for everybody. Um, and that's why I think things like social media and podcasting are also so important, because you have to get good quality education out to people, and doing it in our appointments one-on-one, is often not going to be able to move the needle in terms of teaching all the people we need to teach. So that's like the really long
That's the
answer
overview.
to that you didn't ask for.
All good. All good.
Yeah, and then in terms of this past year, so I mean, my daughter is just about to celebrate her first birthday.
Oh my gosh,
So
congratulations. You made it.
thank you. I cannot believe it. Is it easy now?
No, no, no.
I, you
My
know,
kids are 10, and I'm going to have a 13-year-old in February, which is completely blowing my mind because he's still my baby. So no, it just gets different. You'll be fine. Don't worry about it. Don't worry about any of that later stuff. It'll come when it comes. You'll all be good.
Oh my god, I know, it's so funny, because my child's undergoing this sleep regression, and she's
Mm,
had been a really great sleeper, and now she's waking up every 2 hours, and, my husband was talking about it to a friend of his, and they're like, "Okay, but she's not a teenager, and she doesn't hate you yet, so just enjoy it."
yeah. Yeah. No, no, no. I have active conversations with my 10-year-old, and she's delightful. And she's like, Mama, someday I will not hate you. I promise you. I'm like, no, honey, you're gonna hate me. Let's just get that cleared up front. I know you don't mean it. She's like, no, 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 I love you. I'm like, but someday you will say that you hate me. It's fine. All good. We're
It's
planning
so
for it.
funny. So I remember, do you remember DARE, like,
Mhm.
in school?
Yep.
Right, the listeners who are not millennials, it was the drug and alcohol education program,
Yep.
in schools in the whatever 80s, I
Yep.
guess, and I remember in DARE, us all sitting around being like, "Oh, yeah, we'll never try alcohol." "Well, that sounds so bad. I would never try alcohol," and every kid in the class was sitting in this circle saying, "Alcohol sounds horrible."
Right.
And then fast forward to college.
Yeah,
And
I was gonna say your first night in college, or if
right,
not before.
right, right. But probably when you were 10 years old, you sat there and said, "No,
Mhm.
I will never do that."
Yep.
So
Yep.
so I totally get it about the 10-year-old saying that they will never say they hate you
Yeah,
because,
exactly.
just
Exactly.
there's just the phases and it happens.
I was
But
chuckling in the back of my head. I was like, "How is she gonna connect DARE to sleep regression?"
oh
But,
yeah, I don't my brain goes
I'm
a little
never gonna have a
bit.
kid. I'm never my kid well, no, but I think that's a good point though, is because you always think that, like, your kid will sleep like, it's just somebody else's kid that won't sleep. My
Yeah.
first did not sleep the first 5 years of its life. He does sleep now, thank God, so it's a wonder I had a second, but I try not to share that with people because they either think I'm full of shit or they think that, "Oh my god, if their kid's not sleeping, their kid's gonna end up like mine." He's fine, he's great, he's normal, it's all good, but no, I get you. I
Yeah,
get you. They do that, but
yeah,
they will sleep
totally.
one day. I literally had to drag him out of bed this morning. So,
Oh
all
my
right,
god,
we're
that's
gonna
so
make a
funny.
a hard left here and talk
Yes.
about hormones, because there has been so much this year, um, from the very start of 2023 talking about hormones. I think a lot, initiating in like the perimenopausal, menopausal space with the, debunking of WHI. Um, but there's not a lot that we hear about hormone levels in pregnancy and postpartum and how there can be some parallels between in like low estrogen states. So, can you maybe kind of start us off by talking about what kind of general hormone levels, like a normal cycle, and then kind of what happens in pregnancy and then postpartum? Because I think a lot of people don't understand that. And so they have that they don't have that basis of information, and then we talk about sexual health and pain with sex after, childbirth and breastfeeding and all that stuff. They don't know how to connect all these things. So maybe we can kind of start with like the basics.
Yes, great question, and I wanna stay off the top. I think part of the reason our understanding or our general awareness of hormone health in the postpartum phase is such garbage is because there is such absolute focus on the child and this feeling like any part of your body that's not related to the child is not important.
Yes.
And, when I, again, was postpartum myself and had had a crash C-section, so a major intra-abdominal surgery, um, I had multiple visits with the lactation consultant, which was amazing. My daughter had probably 10 visits to the pediatrician because she was low weight and she had
Yeah.
jaundice. And I had one telephone appointment 6 weeks later,
Yeah.
and that was it. Right. And I don't blame my obstetrician's practice because there's no reimbursement for anything else, right?
Right.
And so our healthcare structure does not value the woman's body unless it's providing nutrient to the baby or doing something for the baby, and we deserve to feel good.
Yes.
And you know we are important. So it is so great that we're talking about this. So anyway, to backtrack, in terms of a normal cycle, right? Let's say when you're having your typical um, ovulatory cycle, right? You have um, peaks in your hormone levels. So basically, your estrogen level goes up, and then right around the time you ovulate, then it stays higher for the second phase, and then your progesterone basically goes up during the second half of your menstrual cycle. I'm not explaining that very well, but basically, you have estrogen, progesterone, and actually testosterone also, that have fluctuating levels throughout your cycle, but they are very important in your body. And then after you become pregnant, essentially your estrogen levels become quite high. And those are the highest levels of estrogen you are going to have in your entire life. In fact, there was actually really interesting research that just came out showing that women with a history of estrogen receptor positive breast cancer who became pregnant after their diagnosis and while they were undergoing um, estrogen suppression treatment, who stopped the estrogen suppressing treatment for pregnancy, actually
Yep.
did okay, right? And so that's
Yeah.
like a really really important thing because there are young women who get breast cancer and they still want to have more children, but
Yep.
also to remember that estrogen is like not the boogeyman, and we focus so
Right.
much on estrogen medication, but we have the best case example of ultra high levels of estrogen during pregnancy
Right.
not causing adverse breast cancer outcomes. So that's like super cool. But anyway,
Yes.
so you have these fluctuating levels of estrogen, progesterone, and pretty stable levels of testosterone um, during your regular cycle. Um, the levels are the lowest on average around the time of menstruation and right before. And we could get to that in a future episode about why there's actually a lot of cyclical urinary and bladder symptoms
Yeah.
that can exist right around the time of your period. So hormone related urinary and genital symptoms are not just for peri and postmenopause, not just for postpartum, but they actually can be for reproductive age women with cycles, which is also really important to realize and so under discussed. But anyway,
Yeah.
so
I
we
saw you
move.
post about that the other day, and I was like, I think that's such an important that's why I wanted to have you on is because you take all this stuff that people are just isolating in perimenopause and menopause. It's like, no, we can actually have low estrogen states at other times, and these other things
Yes.
can be applicable. And, these moms that have urgency for or even just women who aren't, having kids are having urinary symptoms and whatnot. And people just don't understand how important estrogen is across the lifespan, how many places there
Yes.
are estrogen receptors in our entire body. Like we just need a
Yes.
estrogen needs like a PR campaign and testosterone and
Yes.
progesterone. I was like, can we
Yes.
just give it? And that's why I'm like, okay, and with our daughters, they need to know up front, that it's not just the girl hormone in 5th grade health class. Like we need to be a little more clear on this. So that's why I was like, please talk through this for me.
Yes.
Thank you.
Yes. No, and I will interject on
Yes.
that. There's a great study, and I need to do a post on social media about this also, but where they looked at urodynamics of
Mhm.
women who were reproductive age women who were menstruating. And they aggregated information on where they were in their cycle and what their bladder symptoms were, right? And so
Mhm.
urodynamics is like a test usually done in a urologist office or a urogynecologist office where they look at bladder filling, bladder storage, bladder symptoms, bladder function. It's in a sense kind of like the echocardiogram of the bladder, if you will. But they saw, you know, over, I think, 1,500 women's tracings that there was a distinct pattern related
Mhm.
to menstrual cycle where it was more common to have overactive bladder around the time of menses when estrogen is lower,
Yep.
right? So there are women who come in and say, I have urgency frequency bladder pain right around the time of my period.
Yep.
And We're like, I don't know why. Well, I have found even in women like that, they could be, let's say, 25,
Yep.
use a little bit of topical estrogen cream around the time of your menses, and you could have a life altering impact, right?
Yeah.
So, like you're saying, it is not just a menopause question, it is not just a perimenopause question, it is not just a postpartum question. It's fascinating, and we could improve people's lives throughout their lifespan, and we just don't
Yep.
talk about any of it. Um, or we say, oh, because you're 25 and you're
Right.
menstruating, your hormones are by definition fine, right? And
Right.
it's so much more complex than that.
Yep.
Um, but anyway, I digress. So back to the pregnancy thing, right? So your estrogen levels are extremely high during pregnancy, and then you give birth and they tank, right?
Yep.
They absolutely tank. And I even remember my older sister who had her first child before me. She's like, I was so prepared for pregnancy. I was so prepared for childbirth. I
Yeah.
had no problems with childbirth. I had an easy delivery. She's like, nobody told me how it felt after the baby comes out. And I felt crazy and
Yes.
my body was shaking and everything was different and nobody
Yes.
talked to me about that. And a huge component of that is the hormones. So basically your levels tank, you go into this menopause like state from the standpoint of low hormones. It's not obviously a menopause like state from the standpoint of your ovary going into this quiescent phase, right?
Mhm.
Um, but from a hormone level, it is menopause like. And if you are breastfeeding, that phase is often much pro- protracted and goes on quite a bit longer. And the reason is because um, the milk producing hormones in the brain actually suppress estrogen production. Now it varies woman to woman, right?
Yep.
And menstruation, ovulation come back even while you're breastfeeding
Yep.
after a number of months, which can be variable. Um, but there is a longer suppression if you're breastfeeding for sure. And the unfortunate thing is like we just don't have a ton of information about when exactly the estrogen levels resume to their normal level,
Yeah.
when exactly um, symptoms related to low estrogen resolve. Like there is no actual medical term for the
Yeah.
genital and urinary symptoms associated with the low estrogen state after pregnancy, which is wild, right? I
Well,
mean, it just
I th
yeah.
I think that most women don't even understand, like, I think they sort of pay attention preparing for pregnancy because if you're trying to track your ovulation and that sort of stuff, you're gonna be down with it. And then once you get pregnant, I think everybody just sort of doesn't pay attention and they're like, "Okay, no big deal.
Yes.
Estrogen's gonna go up. That makes sense." But when you literally think about, like, no one told me about the hot flashes, the first
Hot
week or 2
flashes.
postpartum. What the frick was that? Like, no one told me the
Yes.
middle of the night because 'cause you've got milk coming everywhere, you're sweat like,
Yes.
soaked in sweat. You've got, like, crap
Yes.
coming out of everywhere. No one told me that one. Like, that was not cool. Um,
Yes.
but when you look at it in the rear view, it's like, "Duh, low estrogen, hot flash. You've done this before." And I was like, "How come we don't just, like, put this stuff together?" Like, and why was it that I had to wait? Again, I'd been in this field for, like, 15 years before I had my first kid. Like, where was that? Like, what the hell?
No, seriously. I think about that, right? I mean, I read so many blogs and so many things about how to
Mhm,
prepare for childbirth and
mhm.
pregnancy. And I had read, 50 different a- articles about which stroller to buy
Yes.
and
Yeah.
what playlist to make during labor. Like, who cares,
I
right? Like, when
laminated
you're
my
going,
birth plan, by the way.
Oh my gosh, you
Yeah, my
are,
son has a no, because like,
no,
and
that's impressive.
no, no, but here's the thing. I was being, and I've told this story before. Like I was trying to be considerate, and like, of course, I had
Yeah.
this all planned and blah blah whatever. And my kid never read it. I ended up with a C-section after a 3-day induction. So long story short, don't laminate your birth plan. But again, to your point, you research all this crap, but never once in any of that did hot
No,
flashes come up. Never once, and literally,
I
I
know.
so I'm kidding you not. Like it wasn't until I was sitting here and you said that I'm like, of course, hot flashes, low estrogen. Like, come on. Why aren't we preparing women up front that this is what low estrogen states feel like? And these are the
Yes.
times that you will be in low estrogen states. And one of those will be immediately postpartum. And of course, you've heard of this, but in your head, low estrogen and hot flash, you're thinking of Blanche Devereaux and like Golden Girls. You're not thinking of the first weeks
Yes.
postpartum. I'm like, I don't have white hair. Like,
Yes, and we don't ever portray it anywhere, right? Like
no,
the
no.
all the portrayals on social media of the new mom and she's tired and the
Mm-mm,
baby's waking up and
mm-mm.
maybe even we're starting to portray the true nature of lactation, right? I mean, there was
Mhm.
some show on, I think it was HBO, where the woman like forgot to pump and her shirt got wet and she was
Yep.
sitting at a train station. And I was like, wow, that's cool. We're actually
Mhm.
showing the fact that this is complicated and sucks and we're not just like perfect little
Well,
bottle
but
chests.
some of them, do you
But
remember it was, a couple years ago, it was on Netflix. It was like Sex Life or something like that, and this
yes,
like and it was so messed up because the guy, I don't remember who he was, but he was super hot. And so she's still like breastfeeding, and then she's going off to the city at night and like having not quite an affair with hot ex-boyfriend, and I was like, "No,
yes.
you're not. It's you're
Oh
freaking
my
tired.
God.
You do you're
I
not gonna
know.
be like, "I'm so hot with my milk spots," and then going out and trying to pursue some super hot guy. It's not happening.
No, it's not happening. It's not happening. The
That one
biggest
made me laugh
fantasy of
out
that
loud.
show is that that woman had any interest in
In
any of
sex,
the
right?
dudes. Like, she would have been like, "Oh, no, I have the night off. I'm going to bed early."
Right, exactly,
Not
exactly.
going to find my ex in the
So
city. That
no,
is so
even though
funny.
he was ridiculously hot. But anyway, point being, you mentioned something, in a post lately that I was super excited to see, and it was a play on genitourinary symptoms and menopause, and you're like, "Genitourinary symptoms of lactation." I was like, "Thank you.
Yes.
Thank you very much." Can
Yes.
you kinda dive into that a little bit? Because lots of times women, their symptoms are brushed off by their provider saying, "Oh, just stop breastfeeding and it'll all go away," which, I don't know that that's actually true, but there are, if somebody is lactating, there can be some things that, can be happening.
Totally. So, as you mentioned, and we're immediately postpartum, we're getting these hot flashes, we're low estrogen state, and then when you start breastfeeding, your prolactin is high, associated with the milk production. Continues to suppress your estrogen, and essentially what can happen is that we develop the genital and urinary symptoms associated with low estrogen state, which has no medical term, which I said on social media, we could call genitourinary syndrome of lactation. And those can be all the same symptoms that we typically associate with perimenopause and postmenopause.
Yeah.
So, for example, bladder urgency and frequency, feeling like you have a UTI, even though there's no infection. Um, even potentially some leakage with cough and sneeze,
Yep.
certainly pain with sex. And unfortunately, most people are not educated that these symptoms can be related to estrogen levels, or as you're saying, they just are told to stop breastfeeding, which that doesn't have to be the solution.
Right.
There are other interventions we can offer. And I can say with my own personal experience, I was experiencing those symptoms and I spoke to my OB and I said, I'm having painful sex. And she said, okay, I'll put in the referral to physical therapy. And I knew it was particularly associated with dryness.
Yeah. Yep.
And physical therapy is so important for so many postpartum women.
Yep.
But if it's from mucosal dryness
Yes.
from a lack of estrogen, then the patient's going to end up in your office and they're not going to be successful
Right.
because they're not getting multimodal therapy, right? And
Yes.
so, and I said to her, I need vaginal estrogen. I would like a prescription for that because I knew. And she was like, oh, yeah, of course, no problem. But I wonder if I was not me and not a hormone obsessed urologist,
Yes.
she would have said, oh, sex is painful, go to physical therapy. I would have gotten my referral to physical therapy. And, I'm not sure what would have happened. I'm sure I would have gotten really important advice, but it wouldn't have, but I would have needed that multimodal therapy and I wouldn't have
Yes.
gotten it.
Yeah. And that's where I think, like, yay, we're moving forward that we're actually referring to moms to early PT. But I think so important for those of us that are in kind of the postpartum space. And this is even, coaches and trainers and stuff that have conversations with their patients, like, know when it's something else and know the why behind it. Because yeah, okay, there might be a PT component to it, but if it's superficial, if it's dryness, like you said, if it's mucosal, like, I'm not gonna do anything about that. Like, that's not my jam. But I need to know if their OB isn't going to give them vaginal estrogen, how do I help them find somebody who will?
Yes.
Because their provider may not be up to date on doing that. Their provider might say, "Oh, well, it'll affect your milk. That's why I don't prescribe it, and it's local, so no." Like, those are, and it's not as simple as, "Hey, just go talk to your OB about vaginal estrogen." There's so many barriers. Can you kind of speak to that a little bit and what the challenges are for moms trying to get vaginal estrogen?
Yes. So this is a great point. And as you mentioned, there is a large misconception that using a low dose vaginal estrogen, which is extraordinarily effective at treating this genitourinary syndrome of lactation, there is this misconception that it will affect the milk supply.
Yep.
Part of the problem, again, is when it comes to pregnant or postpartum women or lactating women, there is not enough research because for a number of reasons, right? Researchers say, oh, it's a transient state, so why does it matter?
Right.
Which is kind of BS because you deserve to have quality of life.
Yes.
Again, not just your kid, you are a human
Well, and you might be
when you are
breastfeeding for
postpartum.
a couple of years. Like, it's not,
Years.
like, this is not a short term
No,
gig.
no, for sure. For sure. And thankfully, as you get further out, right? So I think the American Association of Pediatrics recommended that you try to breastfeed up to 2 years, which
Mhm.
is like, that is such a challenge on
Mhm.
people's lives.
Yes.
But thankfully, as you get far out, so you're talking, let's say, past that 1 year, maybe potentially earlier, depending on the person,
Yep.
you do uncouple that lactation from the neurochemical, so
Okay.
you will resume getting your normal estrogen levels essentially. But in those months after childbirth, it is a huge issue. So anyway, um, the misconception that it affects milk supply, right? We know for a fact that it is a local treatment, and even women with breast cancer, right, who have breast cancer, not just a high risk for breast cancer. We know that women with breast cancer don't have adverse outcomes when they're using low dose vaginal estrogen, right?
Yeah.
So if we know for a fact with data aggregated from tons and tons and tons of women that
Yeah.
low dose vaginal estrogen is not going to affect your cancer biology,
Right.
right? Why would it affect the lactation? And I think what happens is there are so many people who have trouble with lactation
Yep.
that if they end up getting treatment for their concerns,
Yep.
and their milk supply goes down or never gets to where they wanted it to be, then they're going to blame themselves and they're going to say, I did this treatment to feel better, to improve my genital urinary
Right.
symptoms, and I use this low dose vaginal estrogen, and my milk supply never came in, or it dropped off. And those could be from a gazillion different reasons,
Right.
but we're going to focus on the one thing you did for yourself.
Well,
You know what I mean?
so many moms, like, to your point, like, there's so much pressure to breastfeed, and there's so many challenges to getting it right, and it's hard AF, like, it is. And even, like, my first wasn't the worst, and my second was hard, and I didn't expect that. And the thing is, like, whenever there's a question in your head of like, if I take this, it might affect my milk. You work so damn hard to get this, and it's the one thing you might have gotten right. Like, I think it just puts this fear that you don't want to put that in jeopardy. And that's why I think we have to start with the education up front of like, actually, no, this is local. It's fine. It's not going to screw with all the hard work that you put in. Like, but again, it's going back to, we need to get these things in people's brains before, because once you become a mom, I feel like you're constantly worried about, the other shoe dropping. You're like, God, I worked so hard to do this. I don't want to mess it up. And even if somebody says, oh no, it'll be totally fine, like, you're still scared. And I
Yeah,
think you got to tell people when they're not under the gun. Like, it's not fair. They're already so stressed out. Again,
totally.
depressive state because they're on low estrogen.
Yes. Oh my
But
God. What percent? I mean, we know for a fact, right, that
yes.
low estrogen affects your brain neurobiology. We know that
Yeah.
depression is much higher during perimenopause,
Yep.
right? Menopause transition.
Yep.
Postpartum depression is a perimenopausal phenomenon.
It is. It is.
And it's
It
never
is.
talked about like that,
No.
ever,
No.
ever. It's
No.
freaking crazy. Um, it's crazy. I was
No.
just thinking about this the other day. Um, but yeah, and I think another, just to talk about more discrete, practical tips about
Yeah.
prescribing for both, healthcare providers who might be listening to this, but also for potential patients and people who are going to be postpartum. There are some tricks I use. For example, the typical, what we call topical estrogen treatment or low dose vaginal estrogen treatment, usually starts with 1 gram, let's say, of a 0.01% cream. So 1 gram every night for 2 weeks,
Mhm.
and then twice a week. And that 1 gram every night for 2 weeks is a little bit of a higher dose
Mhm.
that could potentially be associated with some systemic absorption. So I don't have people start at that, because that is the treatment you're using for peri and postmenopausal
Mhm.
genitourinary symptoms,
Yep.
right? So I just have them start at twice a week, 1 gram twice a week. Or you could do half a gram, right?
Right.
More frequently. Or depending on their comfort level, say, okay, your symptoms are primarily urinary and urethral, maybe you have urethral burning, whatever.
Mhm.
Take a teeny tiny bit and just dab it over your urethra, and then see how you do. And if that resolves your symptoms, you don't even need any more. That treatment
Right.
lasts you 6 months, right?
Right.
Um, we it's not a pill,
Right.
we can tweak it. Um, and then if they're doing well and there's no change in their lactation, which of course we knew there wouldn't be, but they
Right.
needed to see that and feel
Yes.
it in their own body, then they can, as they feel comfortable, work into it a little more, right?
Yeah.
And say, okay, maybe I am going to put this inside the vagina for my vaginal dryness. So there
Yep.
are tips and tricks. Again, this isn't listed anywhere. I don't think that there's no guidelines on this. There's like nothing.
Yeah. Well, I think that's like, it's like good news, bad news. And I mean, our field, I love it because it's constantly changing and improving, and it's a hell of a lot better than it was, 20, 25 years ago when I first started. But I think the other challenge is those of us that are like on top of it, we're like, yeah, let's do this, let's do this. And then you have patients that, they're trying to do the right thing. They go back and they talk to their provider, and their provider says no.
Right.
And for us, it puts us in almost like, as physios, almost in like a subservient position where like, oh, well, my doctor said this. Like, how do we help advocate for our patients to find providers who are up to date with information? How do we find I have a friend actually, she's I guess there's more you would know about this, more of these tech companies that will do kind of telehealthy sorts of things. Like what are some ways to kind of if your provider isn't on board, how can we still get the care that we deserve?
Yeah, and this is a great question, and it's tough in this space because for let's say I have a postmenopausal patient with recurrent UTI and her provider doesn't want to prescribe it to her. I can say, hey, these are all the important studies with level one evidence showing that this
Yeah,
reduces recurrent UTI. So you can go to your provider and be like, this is the important medical literature, not just I Google searched it, but
right,
this is the important medical literature, and this is how I can advocate for myself, right? And then the problem is, again, that there's no medical term for this, right?
right.
I mean, for genitourinary syndrome of lactation or postpartum genitourinary syndrome, right? The same way there's postpartum depression.
Yep,
Um, and there is almost no research on it.
yep.
There are some studies. Our friend Rachel Rubin, who we are talking about before we started recording, had a great abstract on the safety. I don't think it's a fully published paper, but I think if you search Rachel Rubin and breastfeeding and vaginal estrogen, the abstract would come up uh,
Mhm.
showing that it was safe and it didn't reduce milk supply. Um, but it's tough because
Yeah,
the level of evidence is not there. We just know it's true, and we, um, but it's tough. So it's really difficult to advocate for yourself. Um, I would say there are a few different ways. So you can make the argument like you go to your physician and you say, I would like this prescription. I know you might be concerned that it will affect my milk supply. I accept that risk, right?
yeah,
And we know it's not going to do that,
yep,
but it's definitely not going to be harmful to your child, right? So
right.
if they are telling you that you're not allowed to accept that risk, that is very patronizing, right? And
Mm,
we're supposed to be doing a better job at shared decision making in medicine where somebody's allowed to accept their own risks. So if the
yeah,
woman's saying, I am happy if my milk supply goes down and I will give my child formula, I'm okay with that.
yeah,
She should be allowed to be okay with that,
yeah,
right?
100%. Yep,
um, and again, we know that won't happen, but even if you can't convince the provider about that, you can tell them you accept that risk and you want your quality of life. And my hope is that that would allow them
yeah.
to get the prescription. Um, and and it is so tough because I mean, honestly, like this discussion should not even be something that they have to advocate for. It should be part of prenatal education,
Yeah. No,
but it's
and I
not.
think that's the frustrating and like a mom has time to fight with her OB when, she's got all these other things going on. And that's where I think again, providers in my space, we have to be like super educated and super aware of who in our area is informed and who's not. And there's some people that just aren't going to change. And I will say that the newer providers that are coming out, I have so much hope for because they're all on board. And even some of the ones, I think probably the ones that are most informed in the peri and menopause space, I think are coming around on the postpartum because they are seeing the parallels. And to your
Yeah,
point, and I think maybe it was a couple of years ago, Sherella Glacy was saying, she's like, I wish they hadn't put genitourinary symptoms in menopause. She's like, I wish they would have just left it as genitourinary symptoms, period, because that kind of screwed things for this other low estrogen population. But I like your point of accepting the risk because again, like no provider wants to be blamed for low milk. And I think if you go in and be like, I know this is something you might be concerned about. I'm all on board. It's all good. I'm not going to blame you. Then it might be a little bit better. I don't know.
yeah, because there's no argument that not to prescribe it from a safety
Right.
standpoint because it's safe.
Exactly.
And the
Exactly.
only potential physiologic concern is reduced milk supply, which again we don't think is the
Right.
the
Well, I
case. Um, but
I've
that's
had some clients that, like, they go get it, and a week later, they're like, "Oh my god, I'm so much better." And to
yeah,
me, that's also because we triaged it out well. And I think that's
yes.
also a huge role in my space where we ask the right questions, to be like, "All right, well, is this musculoskeletal? Is this hormonal?" And also understanding that a hormonal driver can also result in some pissed off muscles because things are hurting. So understanding kind of order of operations and that kind of stuff too. Like, hey, start this, see how it's going, and then maybe it's a better time for us to get started on the musculoskeletal side of things. So again, if you're just going in blind on musculoskeletal, you're doing your physio patients a disservice for sure. So
Yeah, and
yeah.
so much also, I mean, estrogen is related to um, tissue healing, to cellular
Hmm.
turnover, to vascularization, right? So if you have those patients and they have scar tissue and they're working on rehabbing that, I mean, their low
Yep.
estrogen state is just not helping them. So
Yep.
again, I know I am here wearing my urologist hat and drilling down on like urinary symptoms and vaginal dryness, but just from the standpoint of post-obstetric rehab
Hmm.
related to the trauma that occurred to your pelvic floor, being
Yep.
able to dab estrogen there, they really have a huge benefit.
Little dab will
Um,
do you, right?
right, because you are having
Yeah.
somebody who's having to rehab from one of the most traumatic experiences that their body
Yep.
has ever undergone, and hormonally, the tools are not there.
Yeah.
It's just so hard. So
Yep.
you're right. I mean, in terms of very myofascial components, the hormonal milieu can really affect what you're able to do and the response that they get to the physiotherapy, regardless
Yeah.
of the tissue, the mucosa, right, and the
Yep.
lubrication. Um, so yeah, it's huge. But I also wanted to just touch upon, you were mentioning, new companies out there.
Hmm.
Um, and so yeah, there's so many telehealth companies out there now. Um, that will prescribe vaginal estrogen. Um, you know, I don't work for them, but I noticed that this one company that prescribes vaginal estrogen called Evernow had reposted a video that I did about using vaginal estrogen in women in their 20s and 30s, right?
Hmm.
And the fact that their social media team was paying attention to that and willing
Mm.
to amplify it tells me, oh, maybe this is a safe space for people who are outside of the peri and postmenopause box to access
Yep.
prescriptions like that. And again, I don't speak for that company. I don't work for that company. I don't know. But, if you go online and look vaginal estrogen, telehealth, postpartum, get the vibe, right?
Yep.
Get the vibe. A
Yep.
lot of these companies take insurance. A lot of them, right, have physicians, nurse practitioners, um, who are informed, who are passionate about this area of
Yeah.
care and can prescribe. So that is definitely an option. If you have spoken to your OB and your primary care provider and those folks won't prescribe it to you, I hope that's not the case. But
Yeah.
there are definitely so many options
Yep.
nowadays. And again, I think wherever you go, if it is one of those telehealth companies, approaching them with this, I am informed it's safe for me and my baby.
Yep.
You may be concerned about breast milk production. I accept that risk. Let's do it.
Yeah.
I really, really think and believe that you will have success at accessing those prescriptions.
Yeah.
Um,
Yeah. I think there's such
so
a place for that. We were talking earlier about, growing up in rural areas and that sort of thing. And where I grew up, it was 70 miles to the first, closest major health system. And my friend that found one of those companies, she's like 2 hours from DC, and there's not a lot out there. And I think to have options where maybe the medical care in person isn't as up to date, to be able to still have options to talk to people who are informed. That's one of the beauties that came out of the pandemic, I think, was telehealth and people accepting that. I don't know if they got rid of delivery margaritas or not. That was the other thing that I definitely enjoyed. But one of the two good
No, I
things out of
don't
it, telehealth
know.
and margaritas.
That is so funny. I agree with you. So I had previously been working at a company that did telehealth for women's sexual concerns,
Mhm.
and we did things like treat patients with
Yeah.
vulvodynia, vestibulodynia, right? So for
Yep.
people who may not know, who are listening, pain in the vulvar vestibule, pain near the opening of the vagina in a very hormone sensitive tissue. And people would say to me, how do you possibly think you could treat vestibulodynia
Mhm.
without a physical exam? And I say, okay, if I know this person comes to me and says, it burns when I pee, I have pain with sex upon penetration, it all started after I began the oral contraceptive pill,
Yep.
I'm going to tell you, physical exam is great, but it is so easy to just try a low dose topical
Mhm.
hormone and see if their symptoms improve. And
Yep.
this person, many of the people we treated were in a rural area, had no
Yep.
access to vulvar pain specialists
Yep.
at all, at
Yep.
all. So if you say this person cannot have that prescription until they get the physical exam, they are not going to get help, and they
Ever.
are going to suffer.
Yes.
Yes,
Yeah.
yes. And so
It's healthcare savings here. That's what we're doing.
it's yes,
And improve
yes, and
quality of
I'm
life.
not
Absolutely.
right,
Absolutely.
right, of course. And I'm gonna ask them, right? Like, did you go to your primary care doctor? Did you go to your gynecologist? Yes,
Mhm.
they told me it looked okay, right? So I'm not like saying, "Oh, you have a giant fungating mass nobody's
Right.
treating," right?
Right.
This is somebody with a pain condition that had a clear onset related to hormonal inducing factors, who did go to a local healthcare provider who said their exam was okay.
Yep.
This
It's
is an intervention we can give you. And that's actually incredibly good, effective telehealth and
yes.
incredibly good, effective sexual medicine care,
Yep.
because not everybody can access these specialists. There's just
Yeah.
not enough.
Well, it's
So,
amazing what a good subjective will do. Like your patient, this is why I preach all the time to my students. I was like, they're telling you what's going on. It's up to you to piece it together, and there's patterns to things. And that again, that was one of the beautiful things of switching over to telehealth is I became a better provider because you're listening for those things that when you put it all together, you're like, you know what, I'm gonna go Occam's razor here, low hanging fruit. Obvious answer is probably
yes.
the correct one. And you can get them care faster, and chances are it's going to be the right option. We don't need to get in the weeds on stuff. We don't need to spend thousands of dollars of testing and this and that. It's like, let's go low hanging easy fruit and make some change. So that I will give telehealth a lot of prop for that, and hopefully more people are using it to get to providers that are actually providing good evidence informed care.
Yeah.
So
No,
we could
for
we could
sure. I
talk
mean,
about that for a long time. I
oh my
think.
God. It was funny. I mean, I will say, when I worked at the large managed care organization, they made us do all these training modules on how to like listen to
Mhm.
people,
Mhm.
because they knew that doctors don't do any don't do any good training on how to actually listen to people. I mean, maybe they do nowadays, but when I started med school in 2006, no.
Well, PTs were
And
bad too. We're like, if we can't, all of us are like, oh, if we can't touch somebody, we can't do anything. I'm like, actually, this is the best part up here.
yeah,
Like, I don't
yes,
need to
you're
touch you. I can do it with both hands behind my back.
totally, totally. And yeah, and they had made us do all these training modules on,
Mhm.
you know, how to stop and not interrupt and not
Yes.
because we see, chief complaint when they're coming
Mhm.
in, and our brain is already processing, I have to ask them about
Mhm.
this. And the problem is that all those specific questions that your brain wants to ask could be potentially taking you the wrong direction.
Yep.
So you have to keep your mouth shut and wait
Yes.
at least 2 whole minutes and
Yes.
not say anything.
Yes.
And your encounters will be far more efficient.
Yes.
And so the really important things I make sure to do whenever I talk to patients in person or telehealth is to say, for the first, ideally 5 minutes, but definitely 2 minutes, I'm not going to say anything.
Yep.
And then my next questions are, if they didn't address it already, what do you think might be going on and what are your
Yes.
goals, right?
Yep.
Because you could then go off into this whole thing and tell them what you think is going on, and they said, "Oh, well, I thought it was this, and I did that research, and I was
Mhm.
hoping you were going to say the same thing." And you don't want that to come out in the last minute of the appointment.
No. That's
Um,
that's such a good question and again, I think a lot of and probably in our space too, because I think when you go through I think any of the sort of pelvic issue, I don't care what it is, you tend to go down the rabbit hole information wise. And I think a lot of our patients actually are incredibly well informed. Sometimes it's not the right information, but I think a lot of them do have a good sense of what's going on. And it's again, it's up to us to help them kind of pull that together in a nice collaborative way. So that's a cool question. I'm glad you asked that.
yeah,
Nice.
yeah.
All right. At the end of every episode, we ask everybody a couple of questions. As a new
Oh,
mom, I don't know if you have an answer to this one. Um, what book or podcast? What book are you reading or podcast are you listening to right now?
I'm well, okay. Podcast. I'm very bad, but I guess
It's
the main one
okay.
I listen to is Backtable Urology podcast, which is a very
Ooh.
it's geared towards urologists. So if you're not a urologist, you might not like it, um but then again, there's some really interesting topics. I've been on it before, of
Of
course.
course you have. Of
and
course. Well, why you would
no,
like it.
and they provide a ton of information. So,
Like it.
sometimes, I mean, it's interesting, right? Like the first time I ever learned to do a good pelvic floor exam was when I personally went to a pelvic floor physical therapist's
Mm-hmm.
weekend course. And I
Mm-hmm.
went because I was there to teach about hormones, but then I learned so much
Yep.
and participated in the education. So the point being, sometimes if you find the educational content that's not geared towards you, but actually towards a different profession, you might learn some things that are really great.
I have learned more because again, I think about what we do is such sort of a mashup anyway. Um, I learn a ton from people who are in sports and neuro and orthopedics and urology and GY and like I think that's probably why I really like this is because I really can take what I want and mash it all up and make fun good stuff and the fact that it's all new anyway keeps it exciting. So yeah, I like that.
Yeah.
I
Yeah.
I'm
And
not sure if I'm gonna check out the urology. Would you say backdoor
back
urology?
table urology.
Oh, okay, back table sounds better than backdoor. Okay.
Oh no, back
Urology.
table. So back table, when you're doing surgery, the back
Mhm.
table is where you'll like prepare a
Ah,
specimen.
okay.
So for example, I used to do surgical correction of bent erections, and we would
Okay.
do a dermal graft. And so you'd
Mhm.
take out a piece of dermis from the lower abdomen, and then you'd go to the back
Mm,
table and prepare that piece
got
of
it.
skin
Okay.
for being. Then you go back to the patient and put it on. So the back table urology is referring to
Alludes to that. Okay.
the surgical, yeah. And so they have back table for a number of other surgical specialties. Like I think
Okay.
there's back table ENT or something for
Mhm.
ear, nose, and throat.
I
But
learned
yeah, and
something new
then
today.
I'm not reading it yet, but I was just sent in the mail Dr. Louise Newson, her new book. So I don't know if you guys don't know of her. She's a general practitioner in the United Kingdom who's a huge menopause advocate, and she just put out a book, The Definitive Guide to Peri and Postmenopause,
Yep.
and she sent it to me, and I am excited to read
Awesome.
that because she is an excellent educator. And
Yay. I can't wait to
yes,
hear about that one and dive into that.
yeah.
I'm drinking from the fire hose on perimenopausal stuff right now, so I'll add that one to the list. All right,
But
favorite
like you're saying
activity?
it,
Oh, go ahead.
favorite
No, no.
activity. No, I mean, just like you're saying it, just it taking learnings from that space puts the
Mhm.
light bulb on for our other experiences, right?
Oh,
To say
totally.
to yourself,
Yeah.
"Oh, the hot flashes I had postpartum were low estrogen state, and that
Yeah.
depression was a low
Mhm.
estrogen state, or particularly not the low estrogen, but the tanking of the hormones
Yep.
led to that depression. Um, yeah, yeah. I mean, it's just so powerful.
No,
So
that's
even if
that's a really good point that I think you put into words what I've been feeling lately. Like learning about all this stuff, it's making me look at all this other stuff in an entirely new light and understanding where we're missing the boat on a lot of this stuff. So
yeah.
yeah,
And so
definitely.
much as modern healthcare providers, we're just told like memorize the guidelines. But
Right.
what we really want is an in-depth, nuanced understanding about how
Mhm.
human bodies are working and
Yep.
why. And
Yeah.
we can't always make a patient feel perfect, but if we can help them really understand what's happening in their
Mhm.
body, that's like 90% of what they want, I feel, um,
I like that.
most of the time.
I
So,
like
yeah,
that.
anyways,
Cool. All right. Favorite activity since becoming a mom, and it doesn't have to involve your daughter.
I have no idea. I have no idea.
It's
Sleeping?
totally fine. Sleeping, that counts. I mean, you're still in it. Congrats on making it through the first year. You know, the first birthday party is really all about you and not about her, right?
I
Like,
know.
we had my son's first birthday in a bar. It just so
Oh,
happens
nice.
that, the bar was owned by, like, one of my husband's, like, former fraternity brothers, and so lots of lights and games and that kind of stuff, and they're like, "Okay, you just gotta be out by 2 because that's when 2 in the afternoon, not in the morning." But
Sure, yeah.
that's when other people come in and they don't wanna see the consequences of their actions, and I was like, "Sweet, I'm down with that."
That's amazing. Our
Right?
daughter's party is going to be at a park
Nice.
outside because we live in Los Angeles
And you
and the
can.
forecast is 77 degrees and sunny. And as somebody who grew up in the Northeast, that was
I will take that.
not something with a
No,
you could ever do with a winter birthday. So
no, you
I am quite
cannot.
excited about
You
that.
cannot. I love that. All right, who's somebody and I'll
Yeah.
tweak this question a little bit, like, who's somebody kinda in the hormone space or even pregnancy, postpartum, like any sexual medicine, like any of that stuff right now, like who's lighting you up? Who are you super excited about?
I would say, have you read the book Estrogen Matters?
I literally just got delivered to my house on Friday. It's on the desk.
Nice, amazing. So yeah, the book Estrogen Matters, and the author is the Avram
Yes.
Blooming.
Yep.
Um, but you can follow the Estrogen Matters social media account. Um, it is phenomenal, and I think really, really eye opening. And takes a deep dive on the Women's Health Initiative study, which was a $1 billion study that completely transformed women's peri and postmenopausal healthcare in the United States, and not for the better. And this goes through it with a fine tooth comb and discusses what was found, why we shouldn't take that at face value.
Right.
And, I think when we're talking about things like the safety of estrogen, being armed with really, really important nuanced understanding of
Yeah.
estrogen and its safety is so important.
Yeah.
And it's something I didn't learn in med school. I didn't learn I mean, we learned the WHI study in med school,
Right.
not why it was bad. And so we
Right.
learned that. We didn't learn it in med school. We didn't learn these things in residency. And that book is phenomenal. So that would be someone you should know about. And if you don't
Awesome.
even read the book, then you can follow Estrogen Matters social
Yeah.
media accounts.
Yep. There's
It's
so
really easy to
much good
understand.
stuff on social right now, and thank God the algorithm caught up. And so I'm getting some better stuff for sure.
Oh,
You
for
gotta
sure. I
you
mean,
gotta
that
watch those
yeah.
one-offs that pull you in the wrong way.
My Instagram is all people providing really nuanced healthcare information about hormones, and then
Mhm.
somebody being like, "Here's a makeup tutorial, 2016 versus 2023," and then
Yeah.
some 22-year-old is pouring an entire bottle of foundation on her face,
Mhm.
and I'm like, "No, no."
Well, maybe next time she's putting, like, estradiol on her face. I've seen that too. So
Oh, yes, yes,
all right,
yes.
last
That
one,
is an
last
area
one.
that needs more research because
Just a little.
yes.
All right, for you wrapping it up here as a mom, what does it mean to you this first year being an active mom in postpartum? You're just, like,
Doing
staying vertical.
things doing things for myself,
Yeah.
Last weekend I went to a sex positive brunch party
Yay.
and there were no children. And my husband stayed at home with our daughter, and I got dolled up and I brought my white elephant sex toy gift and hung out on a patio overlooking the hills of LA and drank mimosas,
That sounds amazing.
and it was glorious.
That sounds
And
amazing.
so to me, being an active mom postpartum is not getting a really good jogging stroller. It's when I have time doing something for myself.
I
That's
love that. And I will like credit where credit's due. I'm so glad that, when socials got a little bit busier and people were paying attention more that my kids are older. I can't imagine trying to put out information and keep people informed and trying to raise a small one. So I totally bow down to those of you with new little ones, and you're keeping all of us up to date and kind of still like screaming from the rooftops, hey, we need to pay attention here. And that's no small feat to do those two things. So as one mom to the other, I appreciate you. As a professional one to the other, I appreciate you and all of that. So if you want
I
to learn
appreciate
more,
you.
thank you.
Yeah.
If you want to
Sorry,
learn, you're all good. You're all good. If you want to learn more about Dr. Ashley Winter, you can go to Twitter and find her there. I'm going to try and keep encouraging her to get over on the gram. Show a
I've
little
been
more of
doing
her
more for the
smiling
last
face.
week.
I know, and I'm so happy for this. You
Yay.
can find her,
Yeah.
Ashley G. Winter, over on Instagram. Dr. Ashley Winter, thank you so much for all you do, and congrats on making it through that first year as a mom. You got this.
Thank you. Thank you so much for having me and having these important conversations.
Thanks.
Did you enjoy the podcast? If so, leave us a 5-star review on iTunes and tell a friend to do the same. Are you a postpartum mom or postpartum pro wanting to know more about getting back to running after baby? Check out all my free goodies on carriepagliano.com. This podcast represents the opinions of Dr. Carrie Pagliano and her guests to the show. The content should not be taken as medical advice and is for entertainment purposes only. Always consult your healthcare professional for any medical questions.